Dear Pure Urology viewers, good evening one and all. Today topic is RIRS basic steps. As you all know, we have stalwarts in India like Dr. Kandar Parikh sir, Dr. Prabhakaran, who are seniors who have done at the first phase learned with large scopes, then RIRS has picked up. Subsequent generations, we have learned, and next after 5 years, our juniors have learned, and some of them excelled, and they are practicing day to day. And their version also is important because they observed these seniors and they acquired their own skill, their own method of doing it. It always matters when you listen from a person who started and the second time who was followed and then modified the techniques. One such urologist is Dr. Yogesh Kaje, who is close friend of me, even though he is junior. We had multiple interactions. He also came to me and I also have gone to Pune, seen his work. I thought since long time I was requesting him to do how the basics of RIRS, what is the common problems he faces, how he puts the access sheet, how he puts the guideware, all things we will come to know through him. So before I hand over the program to Yogesh, I will read about his CV and then is the screen visible? I think, Yogesh?
Yes, sir.
Yeah. So it is video-based surgical presentation on RIRS basic steps by Dr. Yogesh Kaje, who is the director, Ashirwad Urology and Andrology Center, Karadi, Pune, consultant urologist at Sayadri Hospitals, Pune, MS MCH Urology from GS Medical College and KM Hospital, Mumbai, Best Thesis Award during his residency, Best Paper Award, Massicon 2011, rank number 1 in super specialty entrance in exam 2012, various publication in PubMed Index journals. Interested areas are advanced endourology, laparoscopy, uro-oncology, and renal transplant. Before I hand over the program, in the Pure Urology also, which is our official Facebook forum, we are requesting that slowly we ourselves are becoming seniors and sometime we will become super seniors, so that a lot of juniors are coming with a lot of enthusiasm and technical skill, especially endourology, robotic surgery and all. So I request in Pure Urology to discuss and present so that we can identify the younger talent and involve in these type of discussions. Not that only seniors will tell over a period of decades about the surgical techniques. They are anyway involved. They anyway given the laurels to the Pure Urology. But we have to listen from the next generation also how they modified the things, because younger generation is smarter. They can modify the things, the suction, larger sheets, smaller disposable scopes, how the combination of the laser settings, they can enlighten better. So thank you, Yogesh, for the accepting the invitation, and over to you. You do it your own time. There is no hurry. These type of talks will be useful to juniors, I must tell, because 350, 400 urologists will be coming every time outside the MCH DNB exam. So it should be useful for them. Over to you, Yogesh.
Thank you, sir. Good evening, everybody. Thank you, sir, for a very kind introduction and a great opportunity offered to me to present my experience on RIRS on Pure Urology Forum.
Yeah, it is visible and very clear.
Yeah. So the today's topic is what are the basic steps in RIRS? So firstly, let me declare that I don't have any conflict of interest. I would like to share my RIRS journey in a short while. I practically had no hands-on experience of RIRS during my residency period because I did my MCH from a government hospital, and there are certain constraints over there that at that time, because the scopes was fiber optic scope, so the purchase cost, maintenance cost, repair cost is beyond the reach of a government hospital. I was very confident about my PCNL skills because I had done a lot of PCNL during my residency, and when I started practicing, I was very confident about it. But sooner I started practicing in a metro city like Pune, and I felt that the RIRS is the need of a art. So I wanted to learn skills of RIRS, and at the same time, when I passed out in 2015, I started my practice. It was a transition period of the RIRS surgery also. I mean, there was a fiber optic scope prevalent at that time, but slowly, the disposable digital scope started coming into the market. The disposable cost also went down. The introduction of thulium fiber laser, newer high frequency, high power lasers made RIRS surgery much easy. The knowledge sharing also increased because of number of conferences, number of focused workshop. The acceptance for RIRS by the insurance company also started increasing. So during 2015 to 2022, I myself witnessed a lot of transition in the RIRS surgery. I must thank these two gentlemen to make me today, who made me today what I am, Dr. Kandar Parikh sir and Dr. Chandramohan sir himself. I attended a focused RIRS surgery workshop at both the places, and I must say that made me propel during to do my RIRS surgery. So why we need to focus on our basics? Because like a champion athlete who focuses on the basics very ruthlessly, every day he focuses on the basic step to be done correctly, and that's why the ultimate result is best. So if you want to do RIRS, if you want to do RIRS correctly, if you want to become a very good RIRS surgeon, we must follow certain basic steps correctly. So what are those basic steps? We must answer the question that when to do RIRS. That means at least in the beginning, our case selection has to be perfect. How to do RIRS? That is correct pre-op preparation, the correct armamentarium, how to do the procedure correctly, what is the post-op care, and what is the correct post-operative follow-up of the patient. So when to do RIRS? That is which case you must select for the RIRS at least very properly in the beginning of your career. We know that urolithiasis is the most common indication for RIRS worldwide, but there are certain rare indications. We may dilate a ureteric stricture, we may treat a urothelial tumor, but by and large, urolithiasis is the most common indication. We know what guidelines have to say regarding the indication of RIRS. They generally recommend RIRS between 1.5 centimeter to 2 centimeter size range. But we must keep one thing in mind, that the stone is a three-dimensional structure. So volumetry is very important to be assessed on a very good quality CT scan. So I would recommend at the start of the career, one must go for 1 to 1.5 centimeter stones and deliver good results. What are the ideal location for a good RIRS case? Definitely upper ureter, pelvic stone, superior calyx stone and middle calyx stones are easier to be done with RIRS. The inferior calyxial stone, certain consideration have to be taken in mind, and that we will discuss in the next slide. We know that RIRS has no age bar. Dr. Chandramohan sir himself does so many pediatric RIRS cases. I myself don't have that bigger experience of pediatric cases, but certainly age is a no bar. At least in the beginning of our career, we must avoid certain cases. Which are those? Patients who have recurrent who are recurrent stone formers, patients who have anatomical abnormalities, patients who have unrealistic expectations. Yes, they feel that once I do RIRS, I should never get stone again, or each and every millimeter of the stone should be removed from my body. These are certain unrealistic expectations. At least in the beginning, avoid these cases. Let us discuss RIRS in inferior calyxial stone. Definitely, contrast study helps. We must do a good contrast CT scan, that is CT urography or IVP before the before such a case. On contrast CT, we must look for these criteria that the infundibular pelvic angle should be obtuse. So it has to be more than 30 degrees. The infundibular width of the lower calyx has to be more. That means it should be a wide and short infundibulum. And the distance between lower calyx and the upper ureter has to be more. So more the distance, the better is the case result. Previously, when the fiber optic scopes were in use, a lot of surgeons were skeptical to do inferior calyceal stone because it used to produce more torque on the uh, scopes. But nowadays, these disposable scopes have very good bendability, and since the cost factor is not that threatening, a lot of stores are inferior calyceal stores are managed by RIRS these days. Introduction of fans sheath has helped good clearance rate in the inferior calyceal stones recently. Definitely, we must take consent for PCNL whenever we are operating for inferior calyceal stone. And if we think that it is taking too much of a time, don't waste that time because the kidney becomes edematous. Go for the PCNL in a very early phase of the case. I am not very well aware with the supine PCNL. I am a very prone PCNL surgeon, but definitely learning supine PCNL can help you to do inferior calyceal stone without changing the position of the patient. Remember that the intraoperative RGP and actual scopy picture can differ. So don't prepare your mind. Don't be very judgmental depending on the RGP. Go inside and see whether you can get hold of the stone, you can lace the stone properly. Remember, repositioning is a very good tool. We must follow certain basics while repositioning of the stone, that we must see the stone 360 degrees. We need to have a good infundibulum, and we pick up the stone and place it either in the superior calyx or middle calyx, and then lace it comfortably. Regarding pre-op preparation, there is a tendency for us urologists, whenever we do get any juicy case, we tend to forget certain basic investigations. We tend to forget that urine culture is very, very important. So the more important thing is history and examination. History and examination is many times overlooked by the uh, person who is very eager to do his RIRS case. I must say that you must focus on proper history taking and thorough examination of the patient. Regarding urine culture sensitivity, I prefer that the urine culture sensitivity is to be done uh, before posting the case to the OT, but generally it is not possible even in my practice. So my practice is whenever patient gets admitted, on the day of admission and on the day of surgery, I send the urine culture, and if patient gets any fever or post-op, I am ready with the urine culture report. But I must take the history whether patient is having any recent history of fever, or if the blood counts are increased. Immunocompromised patient, you must be very careful. Regarding imaging, one may do good quality X-ray, one may do good quality sonography. A plain CT is useful. Contrast CT is very good. IVP study. These are all tests you can do in the pre-op preparation for the RIRS case. My generally what I do is a plain CT scan before a case of RIRS. Consent is the most important part in the RIRS surgery. We must take consent in the local language, whatever language is the patient understands very nicely. Before confirming RIRS surgery, explain all the modalities to him: RIRS, PCNL, mini PCNL, URS, lithotripsy. Tell all the available modalities. Even medical management has to be done, has to be discussed with him that it has no role, and that's why I'm doing surgery in your case. Explain him regarding the staging protocol, need for staging, need for pre-stenting. Explain patient regarding post-op issues such as catheter-related pain, stent dysuria. Patient sometimes have very unrealistic expectation because they must have read something about on Google that RIRS is absolutely painless surgery, bloodless surgery. You may work on the same day. No, tell patients that RIRS does have certain pain post-operatively, but it can be taken care nicely by the painkillers. Uh, I pre- I always ask my patient to take proper rest for 2 to 3 days. There is no hurry to resume work. Tell patients about the follow-up protocol. Whatever you explain, I personally feel that whenever patient tells you, doctor, do my RIRS case, and you tell them that I will pre-stent you, then I will do RIRS, and after 2 weeks I will remove the stent, patient always get shocked face. So, but spend some time definitely in the beginning of your career. Always explain the need of pre-stenting to the patient. Sometimes I roam around and do cases which are admitted under physician. So I put stent in those cases and I tend to forget. So I always take stent removal consent on the very next day. I take their sign that the stent has been placed in their body. Because they are not my case, not done in my hospital, I should not lose the follow-up of those cases. So stent removal consent is what I do practice. So just we have discussed that sometimes doing in 3 stages every time is, though ideal, certain constraints are there. I work in a corporate hospital. I can't uh, be adamant that I will pre-stent, then only I will do RS, and then only stent removal. So my approach is whenever the ureteral access shift goes very easily in the first case, and if I can finish the job completely, I finish the RIRS as a primary RIRS. If I can't finish completely, then I will do kind of subtotal RIRS. I'll fragment the stone. I'll reposit the stone. After that, I'll counsel the patient and do check RIRS thing after 2 weeks. And at that time, I'll go for the completion RIRS. Recently I've started using fan shape, and mind you, during second stage, I almost get a complete clearance of the stone. So in those cases, sometimes when the case is a female, I put a DJ stent with a nylon thread attached to it and ask them to visit me in the OPD. I take out the stent in the OPD. Or in a male patient, I may do ureteric catheterization, but this is purely my personal experience. And after doing 2000, around about 2000 cases of RIRS, I have gained this confidence. I won't recommend this. I won't recommend that it can be generalized. But yeah, proper 3 stage RIRS is hardly 10% of my RIRS cases. We must ensure that the complete clearance has been done. We must respect the tissue whenever we are doing RIRS. We must not dilate ureter forcefully. We must not injure the ureter forcefully. We must respect the PU junction, and we must ensure the strict follow-up. Regarding sterilization protocol, yeah, I still do hybrid sterilization. I still follow hybrid sterilization protocol. During many cases, I have this long chamber for my Sidex chamber. I do high level disinfection using Sidex, and I have a ETO facility also. So after every 3-4 cases, my scopes go for ETO. I have 5 biorad disposable scopes, but generally I prefer Sidex sterilization. Steroid I don't have, but we all know that it is the best form of sterilization. What are the key steps of RIRS? It starts with a very good semi-rigid ureteroscopy. In my personal experience, I always do semi-rigid ureteroscopy in each and every case. Then there is a need for ureteric dilatation, SOS need for RGP. Then comes the access shift placement, then flexible ureteroscopy per se, proper irrigation, laser lithotripsy. If needed, we reposition the stone. Then we do laser lithotripsy and stone retrieval either using basket or fan shift. And post surgery, stenting, ureteral catheter, or sometimes if there is a hardly a check RIRS, we do pickup store. We do no ureteral stenting. So why we need to do ureteral semi-rigid ureteroscopy? It gives us the idea about the ureteric orifice. We can assess the caliber of the ureter. If my 6 by 7.5 French ureteroscope goes easily into the ureteral orifice and it can reach to the upper ureter, yes, I am very much confident that the primary RIRS is on the cards. We can see if there is any calculus or a fragment lying inside the ureter. If we just put a wire blindly and put a access sheath over it, that calculus can cause a long longitudinal tear on the ureter. Putting semi-rigid ureteroscope passively dilates the ureter during primary RIRS. If we do RGP, it can give us a good roadmap. If there are any surprising findings such as any ureteral mass, we can get a good idea. Regarding ureteral access sheath, the most important factor in RIRS is distensibility of the ureter. Ureteral access sheath has an advantage to reduce intrapelvic pressure. With the use of ureteral access sheath, you have less chances of sepsis. You can enter the ureter multiple times, remove fragments very easily. Ureteral access sheath definitely protects scope. Definitely there is no need for any urinary bladder drainage. Fans access sheath additionally offers us very good suction. How to place ureteral access sheath we'll see in the upcoming video, but ideal placement is 3-4 centimeters just below the UPJ, and externally the outer portion of the ureteral access sheath should be near the uh, penis in a male's case. You should keep always new ureteral access sheath with you because it has a very good chance to pass into the ureter because of its very nice hydrophilic coating. So audio is not visible like this. Audio is not audible like this.
Yeah, audio is not there. You can speak.
Yeah. So this is my so this is my RIRS trolley. I have RIRS trolley separately and disposable trolley separately. I have a semi-rigid ureteroscope, long triaphragm forceps to remove the degestant. Once I remove the degestant, I pass a guide wire, Terumo guide wire, and over guide wire, I pass this ureteral access sheath. 45 centimeter I use in case of males, 35 centimeter I use in case of females. Always pass ureteral access sheath under a fluoroscopy guidance. Then I do have a biorad semi-rigid ureteroscope. The parts of the semi-rigid ureteroscope you already know that there is a handle, there is a shaft, there is a bendable distal portion, there is a lever. So let me take you to my accessory trolley. I always have a straight tip Terumo guide wire using which I intubate the ureter and pass the access sheath. Sometimes during primary RIRS, I am not able to dilate the ureter. I use zebra wire and a brand new access sheath. I am able to cross the UV junction very nicely. This is the balloon dilator by Cook company, but frankly, I hardly use it. And a ureteric catheter if needed. Baskets, I have all types of basket, but I hardly do basketing these days. This is a GPO basket from Byrad company. So here I am explaining the basic movements of the RIRS scope. So every RIRS scope has two intuitive and two counterintuitive movements. So the first movement is forward entering into the kidney. and coming back to the ureter. So forward and backward movement. This is intuitive. When you want to move forward, you take the scope forward. Whenever you want to come back, you take the scope backward. The second set of movement is bending down and bending up using the lever. Whenever the lever is pulled down, the scope bends down. This is a logical scope. Whenever you pull the lever up, the distal portion goes up. The third set of movement is internal rotation and external rotation. So if I want to enter into the left kidney, so left kidney is on the left side of the screen right now. So I will internally rotate. So I'll take my palm onto my left shoulder. I will internally rotate, and you can see the inside movement is happening exactly opposite to my outside movement. And whenever I want to go into the right side, I'll do the external rotation, that is palm out. And I can go into the right kidney, lower calyx. So this is internal rotation, external rotation. Yeah, internal rotation, external rotation. Counterintuitive movements, these are. So third set of movement is the rotational movement. Using the other hand, we rotate the shaft clockwise, anti-clockwise. This maneuver is typically used to reach to the anterior calyx of the respective kidneys. These are again counterintuitive movements. So right now I'm in the left kidney, and if I want to see the anterior calyx of the left kidney, I will do anti-clockwise movement. And similarly on the right side, if I want to see the anterior calyx, it's the clockwise movement of the shaft. The last movement is the passive flexion. Passive flexion occurs at the level of the pelvis when the bendable portion is passively bent against the pelvic wall. This passive flexion movements assist the active flexion movements inside, and we get a very good reach to the lower calyx. So here I am explaining the typical OR setup. This is a left RIRS case. You typically need a very spacious OT for RIRS. You don't want yourself to struggle, your staff to struggle. There are lot many instruments. So always ask for a good spacious OT whenever you are doing the RIRS case. So in case of a left RIRS, one second.
No problem. When you are sharing, you also share media visibility. What is that? Media visibility. Stop sharing while sharing. Whenever it is intermittently stop, you can share. What is that word called? So it will. Okay, share it.
Yes, sir. Is it visible, sir?
No, not yet. You have to put the share. You have to put share and then enter.
One second.
Below. You have a separate video.
No.
First, you have to go below share. You have to click the share green button.
Green.
On the screen. Yeah, it is shared now.
It's shared now. Yeah.
It is a PowerPoint presentation which you are doing.
Yes, sir.
Okay, right. Okay.
I'll
This
forward this. Yeah.
moment is over. Yeah, right. Here you stay back. Okay.
So for left RIRS, screen is on the left side of the patient. The C-arm is on the other side of the patient. RIRS trolley is exactly on the right side of my body. Laser is also on the right side. I keep laser nearby so that there is no stretch on the laser, delicate laser fiber. Your laser has to be handled by a dedicated person. Patient is in a lithotomy position. I prefer general anesthesia and with low tidal volume so that the lasing is very accurate. During COVID time, I had done cases under spinal also, but the movement of the kidney can sometimes be really troublesome while doing good dusting. So this is how I put the ureteral access sheath. Always lubricate the ureteral access sheath with lot of water from inside and outside. Make sure that the ureteral access sheath assembly is properly fit. The inner obturator sheath is nicely fit into the outer sheath. Otherwise, it won't go. Always do gentle pushing movement whenever you feel resistant. Take the help of fluoroscopy. This is a fans access sheath. So goal while putting fans access sheath is to the bendable portion should reach into the renal pelvis. So this is how I am confirming on the fluoroscopy. This is a right RIRS I am doing. This is a separate video taken from a different case. So always confirm on the C-arm. Yeah. In this case, the sheath was not crossing the UPJ. It is just below the UPJ. But I don't force. Let me see what happens on the visual inspection. And then I take a call. Regarding surgeon's position, it's a purely individual preference. Some surgeons tend to do RIRS in a sitting position. Some may do in a standing position. I always do in standing position. Regarding irrigation, uh, people have different choices. Some use 20 cc syringe with extension tubing. Some use Pathfinder. Some put pressure bags on the routine NS bottles. My choice is simple gravity irrigation using TUR set. Regarding laser lithotripsy, we can deal the stone with multiple ways. We can make it into a golden dust. We can do chipping for a faster surgical to lessen the surgical time. Some people are fragmenters. They fragment the stone, take out the fragments, each and every fragment using basket, or recently fans sheath allows them to clear the fragments very easily. Later on, you can popcorn the stone. Popcorning is easily done when the stone is in the calyx. Popcorning is difficult when the stone is in the pelvis. Laser setting, I don't have any set protocol for laser settings. Few basic things to be remembered over here is that whenever you use high energy, high frequency, the popcorn will happen. Whenever you use low energy, high frequency, the dusting will happen. Whenever you use high energy and low frequency, fragmentation will happen. I'm lucky to have exposure to both the lasers. One is a quanta laser at one center and TFL at the other center. So, but I start with a minimum energy and change over if I whatever I feel if I need to increase the frequency or energy, anything. So these are the general recommendations. Whenever you are basketing a stone, don't basket very big fragment. See the stone completely all around and repose it into the favorable calyx. This is how I use the fan shape. One practical advantage what I have found, sir, while using fan sheet is whenever I used to do a very good golden dust and tell patient that the dust has been made and it will flow out after 2 to 3 days, within 2 to 3 days, patient seems to be unhappy.
Unhappy. Yes,
Yeah,
yes.
and
I agree
say,
fully. Is the dust completely go or not? Uh,
ah,
if you remove fragments and give them one or two, they will be very
yeah,
happy.
they are very happy to see this kind of picture and they feel that, yeah, this is the correct job has been done with me.
Fans has a lot
So,
of advantage. Lot of
yeah.
advantage.
So you keep a negative suction till the stone reaches to the hub and you release the suction and the fragments are collected into the jar. Post-op care is like a routine URS case. You need to give analgesia. Tramadol, opioid analgesic is the drug of choice for me, though it is rarely required. Antibiotic protocol, pre-op antibiotic, and one post-op antibiotic, and the next morning again one IV antibiotic. Third generation cephalosporin is the choice of my antibiotic, and then I discharge them on a oral antibiotic for a period of 5 days. Ambulation is as early as possible, and discharge happens on the very next day. Follow-up is a debatable subject. I mean, what imaging you do, people, if you have a very large stone which is seen preoperatively on X-ray, you can do post-op X-ray with stent in situ and tell them that see the stone is not seen now. USG, what I do generally before every stent removal I do ultrasonography, but yes, they can mention few fragments here and there. So I tell my patients that whenever I'm removing the stent, I will take out all those fragments and make sure that the stone is completely cleared because I'm doing this in the second setting. So I tell them that everything will be cleared, and if necessary, I do sonography again after 15 days. Especially in females, what I have started doing, sir, is I give sedation, take out the stent, and I can quickly finish the check RIRS, even only in sedation. CT scan I don't do. There are people who don't do any investigation post RIRS, so it's an individual choice. So what is the take-home message? RIRS is just an extension of URS. RIRS has rapidly evolved in the past 5 years with a lot of availability. In fact, there is a lot of confusion nowadays. A lot of junior ask me which scope to buy and everything. Even in fact, I haven't used many scopes. I'm stuck with the BioRad scope since beginning. The learning curve is definitely becoming less. RRS is being included in the residential program nowadays. But remember, if RRS complicates, the morbidity can be very high. And for a successful and safe outcome, following basics is must. What is there in future? Miniaturization will happen. RRS will become affordable. Insurance companies have already started accepting it. Government schemes may accept. Something like capsule endoscopy might happen. You put a capsule retrograde, it goes up into the pelvis, do the job. Robotic RRS already been done by the Turkey people, but it may happen regularly. There are many unanswered questions whether RRS will be done by unqualified people or not. So that's a debatable subject. So alertness, that is following the basics, knowledge obtained from a reputed teacher, own practical experience, and maintaining hygiene is the perfect qualities for a very good doctor. Thank you.
Thank you. Thank you very much. Nice, crisp presentation.
Thank you, sir.
We will stop sharing. Yeah, stop sharing. So, Yogesh, a few questions I will ask. Generally, if the patient asks for stone, large size stone, I came to you because you are known for RIRS, 3 centimeter stone. Please do RIRS. I don't mind paying you. What are the things that comes in your mind for the safety of the patient? He is mentally prepared for RIRS, RIRS, RIRS. Honestly, I am fed up. When I wanted to do PCNL, they say that we came only for RIRS to you, and why are you telling PCNL? Same thing I might have got it in my district. Then we are in our heart will say, no, 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 this case is not for RIRS, but our brain thinks that I will lose the case. So how do you, I mean, don't think it's a big question. It's a very common problem. When you
Yes.
become known for certain surgery, you have to
Yes.
deal with the advances of the surgery also. So what is your cutoff and how do you take the patient for a large volume stone is my question, straightforward.
Sir, my largest size up till now has been 2.5 centimeter. Frankly, I haven't done
Very good.
RRS in 3 centimeter stone.
Very good. Very good.
I try my level best to convince them for PCNL.
Excellent.
But few colleagues of mine, few juniors of mine are doing that's what they are claiming, that they are doing RRS for 3 centimeter stone. I find it very uncomfortable.
Uncomfortable. Even I say after 20 years of experience, I am very uncomfortable. There is no question of junior and senior. The principle is same, guidelines are same. As the expertise increases, we can do. Still, I say 3 centimeter no. Except in certain conditions like ectopic kidney pelvis, I will do in 2 settings because PCL in such cases will be laparoscopic assisted, complicated. But routine easy case for PCNL, pelvic stone in the normal kidney, which finishes in half an hour. Puncture you have to learn anyway. So why to do 2 setting, 3
Yes,
setting,
sir.
and powder, residual stones growing, infection, colicky pain, fever, stent removal, again stenting, again relook. He has to pay for it in corporate.
Yes.
For individual, I am a hospital owner, so I don't have problem. But we charge only medicine. But it's cumbersome. Whenever you do surgery without any charges and stress also, once the RIRS gets fever, going
Yes,
back into that kidney is very difficult.
yes, sir.
So in such situations, 2.5 centimeter मान के जाओ आपने fix कर लिया. Do you like to stent and do these cases, or okay, you try once with the sheath first?
Sir, in that case, I always do rigid ureteroscopy. If it goes nicely,
You do. As you said, you will do 80%, 90% कर ही दोगे.
Yeah, सब total कुछ तो कर देंगे, हाँ.
कर देंगे. You will do it. I mean to say.
Yes.
Right. This is my first question. Second question. Do you keep second guide wire small? Generally, I don't keep. Many doesn't keep. Have you ever felt that 2 guide wires are required?
Sir, this is obviously a learning platform, and a lot of juniors are watching this. But practically, I don't use guide wire. Initially, using access sheet, if I want to reach to the pelvis, I used to railroad it over the guide wire.
Yeah.
But once my experience built up, I'm not using even a single wire. I haven't used 2 wires at any point in time.
So in RIRS, in one condition, I say, in pediatric ureters, upper ureteric folds will be there.
Yes, sir. Yes.
What happens? You insert the access sheet. By chance, if you come back below that fold, it's very difficult to pass the scope also.
Yes, sir.
Then you have to pass again guide wire through the scope. Instead of that, if already one scope is there, it always keeps the mouth open. Come, go, like that. If you are like this, sometimes if you are frustrated and the last part of the surgery, push it, it will perforate.
Yes.
Less than 2 years children, Dietill's folds are really troublesome.
Okay.
Merge maneuver, two guide wires, one guide wire, two guide wire mean only one guide wire outside the access sheet.
Okay.
Outside the access. First you pass a small wire, then pass a thick wire. Over the thick wire, you pass the access sheet and let the small 0.018 thermo guide wire be inside.
Okay.
By chance, last May, even if you cannot put stent, that will help a lot. By chance, bleeding happens, that will help a lot.
Okay.
By chance, if you come out and cannot go inside, it happens in the initial 50 cases. Sometimes you come out and then fold and you will not be able to go. If when you are using fans, all these problems will not be there. But fans doesn't go into the pelvis. It's a tricky situation sometimes.
Okay.
And
Yes.
a point also I am telling you, the 9 French access sheet, if you pass smaller scopes, you can have safety guide wire through access sheet also, not
Okay.
outside. So you have one guide wire, you have scope, and then now 6.3 French has come. You
Okay.
can put nicely one guide wire inside and scope also.
Like PCNL.
Like PCNL. So it is like in PCNL also we don't keep.
Yeah.
But as you told in the teaching forum, juniors can keep it. See, you never know when the problem comes.
Yes.
So first 50 cases, best you have to do it.
Yes.
So that you get confidence and you go forward, because stone is the commonest sizing.
Yes.
Now coming to the third point, when you are in inferior calyx, you are flexing. Have you any time broken the scope?
No, sir.
I know that you have not broken. Because I might have known if you have broken, you might have told me. When you go in deep inferior calyx, your thumb feels the resistance, saying that I can't press any more.
Yes.
This is purely, I don't know how it happens in robotics. This is purely your feedback from the thumb and brain. Then you will stop. In such cases, if the stone volume is more, do you have any tricks, or you wanted to immediately go for PCNL?
Sir, yes, with fan shape, even if the fan shape doesn't go into the lower calyx, I start dusting it, and that dust is being sucked by the fan shape. That's what I've seen. So it definitely
If
lowers
the scope doesn't go. What I'm asking is, the scope doesn't go. Only very difficulty you are seeing the iceberg of the stone, and lot is below. It is tight already, full. You are flexing, like your body also will flex that time, to be honest. So what will you do?
No, convert to PCNL, sir.
Exactly, that is the answer I want. In disposable scopes, we try, but I'm telling you, if the stone is not seen more than half, if the stone is not moving, if the stone has a broad base, please don't do RIRS. This is my feel.
Yeah, triangular
You
type
are
of
not
stone.
able to see a triangular type of stone, don't do it. If it is not moving fixed, don't do it. If the half of the stone is also not seen, only small tip is seen, you will break that. After that, nothing will be seen. The entire thing will be bottom only. Then you have to convert into PCNL. By that time, edema of the parenchyma will come. What do you say?
Yes.
Yeah, that is that. My fourth question. When compared to previous FlexX2 and PP7, you might have used FlexX2.
Yes, sir.
Now you are completely switched over to disposable.
Yes, sir.
Disposable cost around 75,000 to 80,000.
Yes.
How many cases it is coming honestly to you? You have taken 5. Sometimes you don't know. You think that hundreds you are doing. It will not be there. You have to write down each scope name, each scope used, A scope, B scope, C. Then write down. Then only you can. What is your guess that how many cases? 10, 20, 30, 40. If you use average stones, not like in and out saying that one case is over. Not like that. You have to do lithotripsy.
Sir, I feel my case, it goes around 60 to 80 cases, one scope. Only one scope got damaged within the first 5 cases, and that Biorad people have.
Means you imagine for 70,000, if you get 71,000 rupees is the cost of the flexible scopy.
Yes, sir. Yes, sir.
So future will be revolution.
Yes, sir. Yes.
The smallest scope has come 6.3. My God, it is like ureteric catheter. It's really, really beautiful.
Yeah.
But
Future is.
durability, I don't know. I have used for 4 cases.
Hmm.
Thyroid is definitely durable. There is no doubt about it.
Yes.
So last part of the flexion is little tight. Otherwise, it is very, very durable.
Very light, and you don't feel
Very
any stress on the hand.
Yeah, on the hand. Next, fifth question. You have used holmium laser and you have used TFL
Yes.
and you have a pelvic stone.
Hmm.
You have a one fan sheath or without fan sheath. Both situations are different. In fan sheath, you are making fragments and sucking.
Yes.
Whereas in fan sheath is not there, you are doing powder.
Yes.
So one setting which is very useful for fans is what setting? Which for dusting without fans, what is the best setting you will use?
In holmium,
RIRS,
I
in holmium and thulium fiber laser. Best
uh,
setting.
0.8 energy in holmium and
Yeah.
15 to 20 hertz,
Edge. That's
and
correct. So
0.1 joule in.
less than 1 joule is sufficient in holmium,
Yes,
and
sir.
2 to 20 is the range of the frequency. What
Yes.
about the thulium fiber laser?
0.1 to maybe 100 is my.
Is per popcorn. Even dusting also
Less 50 hertz.
50 hertz.
Hmm.
So 0.1 and 50 for you use for dusting.
Dusting, yes, sir.
Do you use anytime fragmentation mode? No.
Fragmentation in TFL I don't use, sir.
You don't use.
I either dust or kind of chip it for a faster dusting, and then I go for popcorning. And
Popcorn. So you go for popcorning directly at the
yes,
end.
sir, I go for popcorning very early.
Correct. So 0.1 and 50 dusting is good, and 1 and 100, 0.1 and 100 for popcorn is also good. So in among these two lasers in the kidney for RIRS, do you have any slight preference in your mind after 10 years of practice?
To TFL, sir.
TFL. I also use TFL, but I feel one thing is there in holmium, dust is controlled very much. And this is with a lot of experience I am telling, and it's slow, but controlled fragmentation or dusting can be done. But unfortunately, with fans, all these controlled gone.
Yes, sir.
Everything you are making fragments and they are sucking out, and you will get real maja by completely clearing all these stones.
Yes, sir.
Then, coming to the last couple of questions. When anybody junior does, in your first cases, you remember, do you used to put stent and do, or okay, what do you advise the junior who want to, for example, third year has passed out, 3 months he has seen the videos, he wanted to do RIRS in private practice in a clinic or nursing home. Do you ask him to stent and then do after 12 days, or is it okay if the ureteroscope goes, he can do it?
See, he or she must have done URS. So he or she knows how the ureter feels over the scope. If the ureter is felt tight on the rigid ureteroscope, always stand and come back again. Always stand and come back after 2 weeks.
Yeah.
That will be my advice. Don't damage ureter.
One question from Sujan. Sir, can you tell me more about disinfection of disposable scope? Disinfection is disposable scope is same like other scopes. Chemical sterilization.
Yes.
Only thing is that in disposable scope, the wire which is attached, ideally that also should be dipped. At least part of the wire, because it's contaminated, that won't get dipped. That is the problem. Or else somebody has to put heavy object on that. Otherwise it floats. The disposable scope floats, and some part will be in the air. So I keep one artery forceps heavy here and there so that it will go down. Otherwise, it's very light, around 100 grams, like that. That is the observation. Otherwise, as you said, cleanliness is important for a doctor.
Yes.
Now, last 2 questions. If you get a fever after RIRS, for example, you have done today, by evening, high grade fever with chills and rigors, primary RIRS, stent in position.
Yes.
What are the common tips and tricks in your private practice? You naturally get stressed.
Yes.
You don't like it because that is the one complication common. And
Yes,
how
sir.
do you proceed? You have given ceftriaxone sulbactam in the morning. Now,
Yes, sir.
7 o'clock evening, you got a severe fever. What will
Yes.
you do? Urine
Sir,
culture will come tomorrow, not on that day, because you have starting day, it will not come.
sir, I'll share my frank experience.
Frank
Initially,
experience only. Pure urology is only frank experience, not Campbell experiences.
in my starting phase, I did one RIRS patient, went home and had a fever and came back and got admitted. We had to start him on meropenem and colistin. And those days, the government capping, nowadays, I think government has capped meropenem rate. So the
Yeah.
government capping was not there. His eventual bill for urosepsis was more than the surgical bill.
Yes, that is the problem in corporate. I
Yes,
haven't faced this because I did not work in corporate for a long time.
yes,
Nirupanam, if you start using na, so I
yes,
use piperacillin and tazobactam first.
yes,
Or amikacin I will add because lot of the audience will be watching. 150 people are watching. So if antibiotic I have to change from ceftriaxone to sulbactam, I have two options.
yes,
One is give amikacin or second thing is piperacillin tazobactam.
yes,
By the time culture should be there, then only meropenem. 10% of the cases I will switch to piperacillin tazobactam. 1
yes,
to 2% of the cases I will go to meropenem. That is
yes,
very costly affair. Now
yes.
I think it will come around 7 to 10,000. I think now.
I hike up the antibiotic, and in few cases I had to remove the stent also. But then the complete clearance was there, so I was quite comfortable in removing the stent.
Yeah.
And
There is a question from Karthik. Which fan sheet you are using size? I think only one fan sheet is there in
yes,
India now.
Aster.
Aster. Now recently other companies have
I
come.
think Biorad also has.
Irad also has come with a fan sheet. Recently, I was in Seoul. Clear Petra has given me a short access sheet of 25 centimeters for
Okay.
pediatric.
Okay.
Fans, not a normal one. Fans access sheet, 25 centimeter length. It will
Oh,
be
great.
very useful for those who are doing less than 2 years, 3 years. For me, it is useful. I brought two pieces from there.
Okay.
Yeah. So last question. What not to be done in RIRS with your basic for a junior? Don't do this. Tell me 2, 3 things at least.
Don't do heroics. RRS is a very simple surgery. There is nothing to boast about it. You need to be careful. Don't damage the patient. Don't take many heavy stone cases. I mean, size wise. Don't feed the unrealistic expectations of the patient, and follow sterile protocol. I focus on prevention so that I have to cure less patient for urosepsis. So I give
I will
Lasix.
add only one more thing I will add is 6 by 7.5 ureteroscopy up to the highest possible extent. If it goes easily, only do RIRS.
Yes,
If it is not going easily, put stent and come out.
yes, yes,
This is my favorite point, very ABCD of the point. If ureteroscope goes easily up to upper ureter,
yes,
then you put the stent and come out.
yes, sir,
So
yes, agree.
this is the important message. I think we have taken all the questions. Thank you very much, Yogesh. Exactly 150 people have seen the program. And I thank, see, a lot of people want to listen from the medium consultant. You are like a medium consultant. We are 20 years, you are 10 years, there are
Yes.
5 years below. So everybody wants to listen from different perspective. Every time Chandramohan, every time Kandar Parekh he will tell the most experience, I have done this, they will say. But it's now our RIRS era is over. Like we only guide and we want to listen from you. So this is the first step where we want to listen from you. So you narrated very well. Excellent.
Thank you, sir.
Very
Thank you.
nice. Very nice. Thank you very much.